Hey, my dear friends, and welcome to part 2 of female pelvic floor anatomy. And firstly, we will look at this picture where we can look at the important fascia structures of the pelvic floor. So in this picture, we see that here in the front we have the pea bladder. Here is the ureter. This purple thing here is the vagina, and this brown thing here is the rectum. Here is the anus, and here is the rectum. And this part of the vagina we call the anterior vaginal wall. You see this purple thing, this is the vaginal epithelium. And in the back side we have the posterior vaginal wall, the posterior vaginal epithelium. And on the front side, between the bladder and the anterior vaginal wall, we have a strong fascial support. You see this black line here. And this is attached to the pubic bone in the front and to the cervix here in the back. And this is why it's called the pubo-cervical fascia. And if this fascia gets torn or distended, the anterior vaginal wall will lose its support and will start to bulge out of the vagina. And this is when the woman suffers from a genital prolapse. And on the back side, we have the same kind of structure. You see this black structure here, which is between the posterior vaginal epithelium and the bowel, the rectum. And this attaches here in the front to this white structure, and this is the perineal body. Approximately here we have the transverse perineal muscle, and in the back of the transverse perineal muscle we have this fascial structure that is called the rectovaginal fascia. So between the rectum and the vagina we have the rectovaginal fascia. And if this fascia gets torn, for example, from a vaginal birth, then the bowel loses its support and starts to bulge into the vagina. And these women usually suffer from bowel emptying difficulties. So these two important fascial structures are a part of the support of the vagina. Okay, and the next structure that we will dive into more deeply is the anal sphincter complex. So here you can see this red, little more dark red part of the anal sphincter. This is the external anal sphincter, and this little more thin part is the internal anal sphincter. And we will start to speak about the internal anal sphincter. Here is the anus, the opening, and here is the rectum or the bowel. And you can see that the internal anal sphincter is just a prolongation of the muscular layer of the bowel. So here it gets a little bit more thick, and here in this part about 3-4 centimeters in depth and about 2 millimeters in thickness, we have the internal anal sphincter. And when you look at this muscle in the real life situation, it's usually more light than this pink color here. Normally we say it's the same color like turkey meat. And this muscle is a muscle that we cannot control with our brain. So it's an autonomous muscle that works without our control. And normally in all situations it has a constant tonus, so it's squeezing. And this helps us to maintain fecal continence or anal continence, so that air and fecal or stool doesn't just pass out. So it's constantly squeezing. And when we examine this muscle, we put a finger, for example, in the anus and palpate, we should feel this muscle all the time squeezing around our finger. So if this muscle is torn or damaged somehow, then the anus is constantly a little bit open. And this muscle also has a sensory function. So this muscle can feel if there is air or stool in the rectum. So this is how we know if we can let only the air come out or if we have to go to the toilet and let the stool pass out. So the women who has an injury on this muscle, every time they feel something coming in the rectum, they always have to go to the toilet because they never know if it's only air or if it's stool coming out. Okay, so this was the internal anal sphincter. Then we have another muscle, the external anal sphincter. And it starts here more superficially close to the skin. You see that the internal sphincter starts a few millimeters in from the skin. But here we have the external anal sphincter. And this is a striated muscle, and it's red in the color. It's not light pink like the internal muscle. It's more red like a normal striated muscle. And it's usually 3-4 centimeters or so in depth, but it's more thick than the internal muscle. So it's maybe 5 or 6 millimeters thick. And this muscle we can control with our willpower. Normally it's when we are rested, this muscle is in resting tone, so it's not squeezing. But for example, if you stand in the elevator and you feel that you have to let gas come out, but it's not appropriate moment because you're standing in the elevator with other people maybe, then you can actively squeeze with the external sphincter to hold the air inside. So this muscle is normally relaxed, but then when we want, we can actively squeeze with this muscle. So these two muscles play a little bit different kind of roles. Okay, so now we will look at these muscular structures in this 3D pelvic model. See, here we see from the inside, and here we see from the outside these different kind of structures. Here we have the pubic bone, and here we have the tailbone. See here the bulbocavernosus muscle. Here we have the transverse perineal muscle. And then in the bottom we have the external sphincter muscle here. And then if we want to examine these superficial muscles, we can put our fingers here on the labias on the both sides and palpate the bulbocavernosus muscle. And we ask the woman to squeeze, and then we can feel this muscular activity. And we can also look what it looks like when she tries to squeeze the vaginal orifice and close the vagina. And now it's time to take a look at the nerve that supplies all these muscles. Because if sometimes when we examine a woman and we see that she cannot squeeze her muscles, but all the muscles, when we look, for example, with 3D ultrasound, we can see that they are intact. The issue can be that there is actually a nerve injury, so that the impulses or commands from the brain are not reaching the muscle. And the nerve that is innervating all these muscles is the pudendal nerve that we can see here. Gives the signals from the brain to the muscle. And this pudendal nerve, we see it starts from these sacral nerve roots that come out from this S1 to S4 nerve roots from the tailbone orifices. And they merge into one big fused a nerve bundle, and it goes out here on the back side under this piriformis butt muscle, and here you can see it goes down to the leg, and this is called the ischias nerve, the ischias, the big ischias nerve, and a little branch from that you can see here. It's going inside this little canal behind a ligament. Here you can see a quite tight spot, and this is called the Alcock's canal. And some people who like cycling sports, they sit on the bike for a long time, they can get a lot of pressure on this Alcock's canal, and this little pudendus nerve can sometimes get entrapped and damaged if you squeeze too much on this Alcock's canal. All right, and this pudendus nerve, it goes in this canal and comes down up here and reaches both the muscles but also the skin and the sensory functions of the female pelvic floor. And for example, when we suture a perineal tear, we put some local anesthesia in this part of the nerve, here. Okay, so now we have spoken about the superficial muscles and the intermediate layer of the muscle. And when we take away these superficial and intermediate muscles, we have the big levator ani squeezing muscles. So here we have the superficial muscles, where I'm pointing here, and here we have the deepest muscle layer, the levator ani. And when you want to examine the levator ani, you should put your fingers approximately 3 centimeters in the vagina. You can open your fingers, and you want to see if the woman can squeeze your fingers together and lift up. Because in childbirth, about approximately 10% of women get levator ani injuries. And you can palpate an injury if you put your finger and feel when it inserts into the pubic bone up here. You can see, sometimes palpate a pouch that you can feel that there is missing muscular substance about 3 centimeters inside the vagina. So this is how you do an examination of the levator ani muscle structure, and I will demonstrate this in a real patient in an upcoming video. Okay, and here we can see these muscles from the inside. It's like a bowl that goes from up to down, and it inserts in the posterior part of the perineum here. So it's attaching to the posterior part of the perineal body. So thank you. This was all for today. And in the upcoming episode, I will demonstrate a gynecological pelvic floor examination in a real patient. So stay tuned and subscribe to the channel so you won't miss these upcoming videos. Have a good day and see you next week. Bye bye.